Something really incredible is happening in medicine, almost behind the scenes. We're in a new era where adults born with heart conditions aren't just surviving childhood anymore. They're looking at living full, long lives. But that amazing success has created a brand new challenge. How do we actually care for this population for the next 50, 60, or even 70 years? Well, the new 2025 ACHD guidelines are the first real roadmap for this, and we're going to break down what makes them such a game changer. Okay, get this. This fact is pretty mind-blowing. There are now more adults living with congenital heart disease, or ACHD, than there are kids. Just let that sink in for a second. Medical science has gotten so good at treating these conditions in children that we've essentially created an entirely new and growing adult patient population, and they need a completely different kind of playbook for the rest of their lives. So what is this new roadmap? That's the big question, right? It's really at the core of these new guidelines from the ACC and AHA. And the answer they give isn't just some minor tweak. It's a complete philosophical shift in how we need to think about care for these adults. So why the big shakeup now? Well, it's because the very definition of success has changed. We've totally moved past the old goal, which was just getting a child through to adulthood. The new frontier is all about helping them thrive through every single stage of life: college, careers, starting a family, and all the complex health challenges that come with it. This document is the first major update in 7 years, and it's built on just a mountain of new research. It's a total move away from that old wait-and-see model to something much more proactive, much more personalized, and really tailored to the unique journey of every single patient. All right, let's start with what is, without a doubt, the cornerstone of these new guidelines. If you take away only one thing, it should be this: specialized, team-based care isn't just a nice-to-have, it's an absolute necessity. And the Guideline Committee is not messing around here. This is a Class 1 recommendation. That's their strongest possible endorsement. So what does that really mean? It means that every single adult with congenital heart disease, even if their condition seems simple, needs to see a specialized ACHD cardiologist at least once. This isn't a suggestion, it's the absolute foundation for their entire plan of care. And this dream team is way bigger than just one cardiologist. The heart is the center, sure, but it's connected to this whole universe of other specialists. Of course, you've got your surgeons and your imaging experts, but what's really crucial here is the new emphasis on experts from outside of cardiology. Why a geneticist? To figure out the root cause. Why a psychologist? To help manage the incredible mental toll of living with a lifelong condition. See? It's about treating the whole person, not just the plumbing of the heart. All right, so you've got the dream team assembled. Now what? How does the actual day-to-day treatment change? Well, the guidelines are just packed with clinical updates that are going to reshape how things are done. Let's dig into some of the biggest game changers. Okay, quick detour, but this is super important so you can understand what's coming next. You have to know how to speak guideline. Think of it like a traffic light. A Class 1 recommendation, that's a bright green light. The evidence is solid. This is something doctors should do. Down at the bottom, Class 3 is a hard red light. That means a treatment isn't just unhelpful, it could actually be harmful. Everything else is kind of like a yellow light. You proceed with caution and good clinical judgment. So keep that traffic light in your head. First up, heart failure. This is a massive long-term risk for these patients. And for the very first time, the guidelines are saying we can't just copy and paste standard heart failure drugs. They have to be specifically adapted for the unique plumbing of ACHD patients. It also gives the green light to start exploring these newer, really powerful classes of drugs. The ones with the long names like ARNIs and SGLT2 inhibitors that have been so successful in other patients. The message is pretty clear. Be more aggressive, be more modern, and call in the top-tier heart failure specialists when things get complicated. Now, this next one is huge because it's brand new. An entire section on managing cyanosis. That's the condition where low oxygen levels can cause a bluish tint to the skin. The guidelines recognize this isn't just about skin color. It is a systemic problem that affects the entire body. So it calls for proactive screening for really serious stuff, from blood clots and strokes to even rare tumors that can be triggered by years of low oxygen. And if you want a perfect example of this new, smarter approach, just look at this decision map. This tackles one of the most common and difficult questions in ACHD care. When should we replace the pulmonary valve in a patient who had tetralogy of Fallot repaired as a kid? Let's just walk through it real quick. The first question at the top is simple. Does the patient have symptoms? If the answer is yes, boom, the path is pretty clear towards replacement. But if the answer is no, things get more complicated. The chart then guides the doctor to look at hard, objective data, things you can measure on an MRI, like the size of the heart's chambers, or see on an EKG, like dangerous rhythms. See how that works? It turns what used to be a subjective guess into a decision driven by data. That is a massive win for patients. You know, one of the things that makes this guideline so revolutionary is that it finally, formally recognizes that you can't just treat the heart in a vacuum. You have to care for the entire person and all their life goals. Which brings us to genetic counseling. For the first time, we're seeing really detailed recommendations about this. This is all about understanding the why behind a patient's condition, and just as important, what it could mean for their family and their future children. And listen, this is not just some nice-to-know information. This has huge real-world consequences. For one, it helps patients understand the actual risk of passing a condition onto their kids. But sometimes it goes even further, and it can uncover other related risks. For example, a genetic test might point to something like Noonan syndrome, which can come with a higher risk of bleeding, something you absolutely need to know before any kind of surgery. And building right on that, the guidelines dive deep into reproductive health. This has been a huge area of uncertainty for patients for so long, and these new recommendations finally provide some much-needed clarity. And the advice here is just incredibly clear and empowering for patients. It says, talk to your specialist before you start any fertility treatments. And get this, don't just assume a C-section is the default option. In fact, it could actually be riskier if there isn't a specific medical reason for it. And for almost every patient, there should be a detailed, personalized plan for pregnancy and delivery. This is just a massive step forward for patient autonomy and safer family planning. And finally, to really round out this whole person approach, the document formally acknowledges how important mental health is. Living with a chronic condition is tough, and recognizing the need for psychological and even neurocognitive support is a critical piece of true comprehensive care. So, you step back, you look at all of these changes together. What does it all mean? What does the future of care for these patients actually look like? Well, it's less about individual fixes and more about a fundamental change in how we see things. Basically, this new roadmap changes everything. We're moving away from just fixing problems as they pop up to a model of proactive, lifelong planning. It's about tailoring care not just to a patient's unique anatomy, but also to their life goals, making their quality of life the ultimate yardstick for success.
But, medicine never stands still, right? A guideline like this is amazing, but it also shines a light on what we don't know yet. It points us toward the next set of questions that we desperately need to answer.
And I want to leave you with this one question, pulled straight from the guidelines section on future research. It asks if we can take all these successful heart failure strategies we've developed and apply them to one of the most complex groups of all, patients who are born with only a single ventricle. It's the perfect ending, really, a hopeful reminder that this roadmap will keep evolving, always pushing the boundaries of what's possible for these amazing patients.